Okay, so good afternoon to everyone. Welcome to the webinar. The first speaker, the first presentation is from Jaume Català. Jaume Català-Mora is the head of the retina unit at Sant Juan de Dios and Joan de Deus Hospital here in Barcelona in Spain. He also coordinates the National Reference Center for Pediatric Intraocular Tumors, and he is the president of the Spanish Ocular Oncology Group and has pioneered to the introduction of intraarterial and intraocular chemotherapy here in Europe, and also led the first clinical trial using an oncolytic virus for treatment of patients with intraocular retinoblastoma. And he's going to talk us about the ophthalmologist perspective and a global perspective from the retinoblastoma and the last advances.
Hello, I am Jaume Català-Mora, pediatric retinal ophthalmologist and coordinator of the National Reference Center for Retinoblastoma at Sant Joan de Déu Hospital in Barcelona. During the next 15 minutes, I will talk about the epidemiology and origin of retinoblastoma, how we can diagnose and treat it, and we will also try to comment on the future developments in the field. Retinoblastoma is the most frequent intraocular malignant tumor in infancy. Each year, 8,000 new cases of retinoblastoma are diagnosed worldwide, representing 11% of cancers in children less than 1 year of age. The disease results, in most cases, from biallelic inactivation of the tumor suppressor gene RB1. Bilateral disease accounts for 35% of all cases. The annual incidence in the world is around 8,000 cases per year. Asia and Africa, with the highest natality index, account for more than 80% of the global annual incidence. Around 500 children are diagnosed of retinoblastoma every year in Europe. The RB1 gene plays a main role in most of retinoblastomas. It is the first tumor suppressor gene described in medicine. Dr. Adela Escudero will develop all the genetic characteristics of this condition later. We mainly have to know that there are some cases which are sporadic. Usually they develop unilateral and solitary tumors, and 30% of the cases are hereditary, and they usually develop bilateral multiple tumors. We have also a set of mosaicism patients that could have unilateral or solitary tumor in this group of hereditary patients. Retinoblastoma originates in the retina from two different tumor precursors. Around 2% of retinoblastomas are caused by MECN amplification without RB1 mutations. They develop from an immature cone cell precursors in the retina, and they develop more aggressive subtype 2 tumors. On the contrary, RB1-related tumors develop from maturing cone precursors. Initially, they form non-malignant lesions called retinomas, but further chromosomic changes in the cells turn them into subtype 1, more differentiated retinoblastomas. These tumors may accumulate further epigenetic and gene expression changes that could turn them into mixed subtype 1 and 2 regions or more aggressive RB1 loss subtype 2 retinoblastomas. Aqueous humor and blood cell-free DNA analysis try to identify and classify patients' tumors for better diagnosis, treatment, and follow-up of these patients. Now we are going to discuss about the diagnosis of the retinoblastoma and from signs and symptoms and ancillary tests to the classification. Leukocoria, a white pupillary reflex, is the first sign of retinoblastoma in more than 60% of the cases. Strabismus occurs when central vision is lost, secondary to macula involvement, and it is found in 20% of the cases. Atypical signs can masquerade other conditions such as uveitis, presumed trauma, glaucoma, or cellulitis. In Europe, less than 3% of retinoblastoma patients are diagnosed with extraocular disease at the time of presentation, while these conditions happen in around 10% of the cases in middle-income countries and up to 45% in low-income countries. In this context, late-presenting signs such as ophthalmic eyes with neovascular glaucoma, ephema, non-infective orbital cellulitis, and proptosis predominate. Retinoblastoma is the only pediatric cancer presenting with recognizable signs, allowing awareness campaigns with significant shortening of the time to diagnosis, improving patient and ocular survival in both developing and high-income countries. Pupils reflex examination must be checked in all children's follow-up by pediatricians and nurses. There are also cell phone apps designed to detect leukocoria in photographs, and further improvements are being tested. Fundus examination, ultrasound, and orbits and central nervous system magnetic resonance, usually under general anesthesia, are the main tools for diagnosis and follow-up of the patients. New tests are more and more used during follow-up. OCT through handheld or microscope-mounted devices is useful for the detection of preclinical lesions and recurrences and to assess macular and foveal status. Ultrasound biomicroscopy is indicated to assess the ciliary body and anterior hyaloid and anterior structures of the eye. International classification of retinoblastoma was finalized by a group of RB experts in mid-2003 to predict treatment success with primary chemoreduction and focal consolidation. In 2006, the Philadelphia version of the international classification introduced subtle but significant inconsistencies. At the initial classification, group EYEs are supposed to be functionally or anatomically destroyed to such an extent that they require primary enucleation, while in the Philadelphia version they included a group of eyes with extensive retinoblastoma occupying more than 50% of the globe, that could be fitted as group D in the Murphy version, and in fact could be treated without enucleation. These discrepancies has made difficult the comparison of results of the treatment from different groups depending on the version of the classification used for the evaluation of the patients. In 2017, we proposed the TNMH classification considering the worst eye condition and including the presence of constitutional RB1 mutation, a condition that affects child life prognosis. Let's begin with the different treatment options. First of all, we have to consider and keep in mind that retinoblastoma is a malignant tumor, lethal if left untreated. So the primary goal of therapy is to preserve life, with ocular survival, visual preservation, and quality of life as secondary aims. It is what Dr. Munier called that we want patients alive with good vision and with no comorbidity. Enucleation is still a very good option for very advanced intraocular retinoblastomas, especially in unilateral disease. It is important to follow the established consensus to evaluate the prognostic risk factors of extraocular disease in enucleated patients. In less advanced cases, we will follow a combined strategy through chemoreduction, mostly intraarterial or systemic, plus consolidation. Dr. María Muñoz, oncologist at our center, will develop this matter later. For the management of vitreous or anterior chamber cysts, we use intraocular chemotherapy to enhance the concentration of the treatment at the location of the cysts. Through a femoral approach, a catheter is advanced to the internal carotid artery and placed in the ostium of the ophthalmic artery. The correct location and arterial circulation is verified by fluoroscopy and the chemotherapy is injected. Initially, melphalan was the treatment of choice, but we tend to combine it with carboplatin and or topotecan. Between 1 and 6 cycles are performed every 4 weeks, depending on the response to treatment, followed by local consolidation therapy. Comparative studies have shown that ocular concentration of chemotherapy via intraarterial are more than 20 to 30 times higher than intravenous, while systemic exposure is only a small fraction, less than 10%, in intraarterial treatment. Tumor control and globe salvage rates are higher with intraarterial chemotherapy. Adverse effects of intraarterial chemotherapy are mainly localized in the eye, while intravenous chemotherapy has a higher risk of ototoxicity and hematologic toxicity as well as secondary leukemias. Once we have managed to chemo-reduce the tumor, we must consolidate the retinal tumors, and we are going to do it with cryotherapy in small anterior tumors, thermotherapy with laser of posterior tumors, and local brachytherapy if needed. Our group at Sant Joan de Déu has recently published the results of a phase 1 clinical trial with our experience with a selective oncolytic virus treating 9 eyes with advanced retinoblastomas from 9 patients. We have had encouraging results with 5 patients showing a partial response and 3 eyes finally preserved with useful vision. One of the most important elements in the conservative treatment of retinoblastoma is follow-up, both in the short and medium term and in the future long term. The first years during treatment, we perform examination and local treatments under general anesthesia every 6 to 8 weeks in order to detect and treat new lesions and recurrences of the tumors. Dr. Muñoz will explain us about the long-term follow-up in these patients. Future directions of retinoblastoma management include liquid biopsy. The use of aqueous humor or even blood as a source of cell-free tumor DNA has been established as a non-invasive method for diagnosis, prognosis, and monitoring treatment response. This approach is particularly valuable since direct tumor biopsy is not feasible for retinoblastoma. Early detection of relapse with higher levels of cell-free DNA in liquid biopsy samples have been correlated with a higher tumor burden and the likelihood of metastatic relapse. This allows for earlier intervention and more tailored treatment strategies. New therapeutic strategies include the use of preclinical models for in vitro evaluation of personalized treatments, and the use of virus and nanoparticles for more targeted and specific treatments to increase the effectivity and reduce toxicity of the treatments. Take-home messages include: retinoblastoma is the most frequent intraocular tumor in children. Leukocoria is the main clinical sign. Early detection and diagnosis increase life survival, globe salvage, and visual function. Molecular gene studies play a main role in the comprehension and management of these patients. The new treatments already applied and in development are more targeted and effective and less toxic for the eyes and for the patients. Long-term follow-up is mandatory for patients and families. All this work has to be done through a multidisciplinary team, including oncologists, ophthalmologists, interventional radiologists, neuroradiologists, radiation therapists, geneticists, pathologists, psychologists, and also clinical and basic researchers. Thank you very much for your attention and for the opportunity to share with you this presentation in this webinar.
Now we'll introduce the next speaker, which is Adela Escudero. Doctora Escudero is a biologist, is a PhD in genetics, and she works as the head of the Molecular Pediatric Hematology and Oncology Laboratory of the Department of Genetics in Hospital La Paz in Madrid, Spain. And she is going to give us a talk about the genetics aspect of retinoblastoma, which are one of the most important things in this disease.
Hello everyone, my name is Adela Escudero and I work as a geneticist at La Paz University Hospital in Madrid, Spain. First of all, I would like to thank the organizers for inviting me to participate in this webinar about retinoblastoma. In the next 15 minutes, I'm going to talk about the genetics of retinoblastoma and how we can improve the genetic diagnosis of this type of cancer. So I'm going to share with you the presentation. As all of you know, retinoblastoma is caused by the inactivation of both copies or alleles of the ERB1 gene, which is a tumor suppressor gene located on the long arm of the chromosome 13. The ERB1 gene encodes the ERB protein, which plays a key role in regulating the cell cycle. Approximately 50% of retinoblastoma patients harbor germline pathogenic variants in the ERB1 gene, and the detection of these genetic alterations is essential for the correct diagnosis, prognosis, and follow-up of these patients. So, genetic analysis of the ERB1 gene for all patients and at-risk family members is part of the standard management for retinoblastoma. Based on when the ERB1 inactivation occurs during development, retinoblastoma can be classified into two types: non-hereditary or sporadic retinoblastoma and an hereditary retinoblastoma. In the first type, both copies of the ERB1 gene are inactivated only in the retinal cells, meaning these changes occur at the somatic level. This type is typically presents as unilateral retinoblastoma and occurring de novo. Patients do not have an increased risk of developing other tumors, and the probability of these patients having children with retinoblastoma is approximately 100%. In contrast, hereditary retinoblastomas involve the inactivation of one copy of the ERB1 gene in all body cells, also known as germline level, while the other copy is specifically inactivated in the retinal cells. Most cases of hereditary retinoblastoma are bilateral, but there are also unilateral tumors, and 90% are de novo cases, but 10% have a family history. And these patients are at a higher risk of developing other ERB-related tumors. The probability of these patients of having children with retinoblastoma is close to 50%. As I said before, most patients with hereditary retinoblastoma are de novo cases. This means that the genetic alteration in the ERB1 gene arise during embryonic development. Depending on the timing of the mutation depending on the timing of the mutation, two situations can occur. If the ERB1 gene mutation occurs at the zygote stage, all the cells of the body carry the mutation, and the patient will be heterozygous for it. In contrast, if the mutation arises later, it will be present in only some cells of the body, and the individual will be mosaic for the mutation. The identification of mosaicism is challenging and depends on the genetic technique, but it is essential for correct genetic counseling, because these patients are at risk of developing retinoblastoma and of having affected children. Different genetic techniques can be used to carry out the genetic diagnosis of patients with retinoblastoma. For example, Sanger sequencing is useful to rule out point mutations and indels, and MLPA exclude deletion. Currently, the most used technique is NGS, which allows us to detect all types of genetic alterations, including mosaic alterations. In addition, approximately between 5 and 8% of patients with retinoblastoma present with developmental delay and congenital anomalies. In such cases, it is recommended to complement the genetic analysis with comparative genomic hybridization array, which can help identify large deletions involving the long arm of chromosome 13. In the next slide, I will show you how we perform genetic analysis in patients with retinoblastoma and how this approach can help us to resolve complex cases and improve the diagnostic rate. The data I will present come from patients treated at my hospital that is a national referral center for retinoblastoma, over the past 25 years. Here we analyze 323 patients using genetic testing, mainly through Sanger sequencing and MLPA. With these conventional techniques, we confirm hereditary retinoblastoma in 50% of the cases. However, in 6 patients with a strong clinical suspicion, no RB1 alterations were detected. To resolve these cases and others, we perform an NGS panel in 74 patients, and we obtain a similar diagnostic rate of approximately 50%. The NGS we use is focused on pediatric cancer and allows analysis of both germline and tumor alterations. It is a DNA-based panel and includes nearly 500 genes, and it is used with the Illumina platform. And this type of panel can identify different types of mutations like single nucleotide variants, indels, copy number variants, and also include the detection of structural variants as fusion genes. This table shows the clinical features and genetic findings in our analyzed patients. As you can see in this graph, most variants were single nucleotide variants and indels, followed by gene deletions, as it was previously reported. But using our panel, we also detected a very rare structural alteration. This structural alteration represent 3% of all the patients analyzed. The following graph shows the distributions of all single nucleotide variants, indels, and deletions identified across the entire RB1 gene. We found that the standard methods like Sanger or MLPA would have missed 14% of these cases, mostly mosaic variants and 1 structural alteration. Importantly, 6 of these patients marked with a red asterisk in the table had been previously undiagnosed with sporadic retinoblastoma. Now I'm going to present 2 of these cases that we could diagnose using our NGS panel. The first one is a patient initially diagnosed with unilateral retinoblastoma, and conventional genetic testing at diagnosis of this patient did not detect any RB1 alteration, and the case was classified as sporadic. Some years later, we analyzed the patient using our NGS panel, and we identified an RB1 variant, arginine 455 stop, with a variant allele frequency of 13%. This variant was classified as a pathogenic variant and confirms the diagnosis of hereditary retinoblastoma in the patient. This was very important for this patient because in that moment she was an adult and she could receive a specific follow-up for her genetic condition and genetic counseling regarding the family plan. The second case is a patient with bilateral retinoblastoma and no other clinical signs. Genetic analysis using the NGS panel revealed no single nucleotide variants or deletion in the RB1, However, we identified the structural rearrangement involving intron 17 of ERN-EYE and an intergenic region of on chromosome 6. This finding also confirmed the diagnosis of hereditary retinoblastoma. This is a very recent case, and now we are completing some experiments to demonstrate the low expression of the ERB protein in this patient. And these two cases, together with all patients undergoing genetic testing for retinoblastoma, were attended at the pediatric cancer predisposition unit that we had in our hospital. This is a multidisciplinary unit in which we see the patients before testing to explain the genetic test, and again after the test to explain the finding and plan follow-up based on the result that we have. To conclude, here are the main take-home messages. First, retinoblastoma is caused by the inactivation of both alleles of the ERB1 gene and could be sporadic or hereditary. Most genetic alterations affecting ERB1 function are single nucleotide variants and copy number variants in heterozygosity. However, other types of alterations can also occur, and we have to take into account this. Third, high-resolution techniques like NGS improve the diagnostic rate and are especially useful in patients with a strong suspicion of hereditary retinoblastoma where no ERB1 alteration were found using a standard method. And last one, genetic counseling is essential for the correct diagnosis, follow-up, and reproductive family planning of retinoblastoma patients. And that's all. I would like to thank all the people that work in the diagnosis and management of patients with retinoblastoma in my hospital, especially thanks to the ophthalmology department, oncology department, cancer predisposition units, and of course the Medical and Molecular Genetic Institute. Thank you.
Thank you, Adela. It's very, very interesting. The last study that she has talked about, the study that they have performed in La Paz about increasing the detection of germinal mutation, the mosaicism and deep intronic variants, because it led us to detect a higher rate of patients with germline condition, and so we can adjust the treatment and above all the follow-up of these patients. So I think it's my turn. Well, I introduce myself. My name is María Muñoz Martínez. I'm a pediatric oncologist at the Pediatric Cancer Center in Barcelona, in Spain, which is an institution who depends from Sant Joan de Déus Hospital. So I work together with Dr. Català, and I'm collaborating with them, with the ophthalmologist team. I'm in charge of patients with retinoblastoma. So, well, after my colleagues, I would like to make a presentation a little bit my perspective, like the oncologist perspective. I've tried not to repeat that much that the message that my colleague has already told, but well, let's see. So trying to contextualize my talk, I would like to begin giving a brief overview of the pediatric cancer, which has nothing to see with the adult cancer. The first difference, which we all know, is in terms of incidence, since for every approximately 200 cases of adult cancer, only one pediatric cancer will appear or will be diagnosed. In addition, pediatric cancer is also called developmental cancer, since it arises fundamentally from errors in cellular development in a period of very rapid growth and appears from before birth, from the first from the conception until the early adulthood. This means that there were different possible cancers of each tissue of the organism, and they came mainly of undifferentiated and embryonic cells, which have nothing to do with the adult cancers, which are mainly carcinomas derived from the cellular aging and with the addition of environmental factors. Adult cancer is therefore the result of an accumulation of many cellular mutations, and adult tumors are characterized for having a high mutational burden. It is not this scenario in the children, in which the tumors tend to be in a that we call cold ambience with little mutation load. And the treatment and the responses to treatment are very different between adults and children. So among the different types of cancer, retinoblastoma is the most frequent ocular tumor in the childhood, but it accounts only for 2% to 3% of the total in this already minority of group of diseases. As Adela has already told you, up to 45% of retinoblastoma cases are constitutional, and almost the 100% in bilateral cases. So all the patients with retinoblastoma should undergo a genetic study to rule out this condition, and all of them should be referred to genetic counseling. This condition, as you know, predisposes to development of the retinoblastoma, but also to other types of cancer, especially in the adulthood, such as melanomas or sarcomas. So another important condition in this patient is that in approximately 2% of patients occur that we call trilateral retinoblastoma, which is a patient who have bilateral retinoblastoma and also another lesion, intracranial lesion, which is usually located in the pineal gland. And it is usually if in cases we diagnosed 50% of the cases we diagnosed in the onset at diagnosis. So, as they told you, retinoblastoma originates in the cells of the retina, and initially, and in the vast majority of cases, it is confined to the eyeball. It is a state from A to E by different groups, and depending on the surface of the ocular surface, and can condition the treatment that we will perform, as Dr. Català has told you. I just tell this to introduce the extraocular disease. I mean, we cannot. We have to know that retinoblastoma is a cancer. I mean, it's a malignant disease, and it is potentially a systemic disease. In our setting, metastases in retinoblastoma are extremely rare because of the programs of detection that we have from this disease. But just to know, the routes of metastasis in retinoblastoma are classically two. One is through the optic nerve, passing to the central nervous system, and through infiltration of the choroid, the sclera, and then crossing into the bloodstream and causing metastasis mainly in the bone marrow, but also in the bones, and extremely rare in other tissues, as for example the liver. So by understanding the biology and the roots of disease spread, we can understand the complementary studies that we have to perform at the onset. After a thorough and a fundamental ophthalmological exploration, we have to complete the tests with a complete blood test, just to detect like indirect signs of disease in another tissues, as well as the presence of comorbidities that may influence the treatment. In addition, an orbital and a corneal MRI should be performed to properly characterize the tumor locally, but also to rule out the presence of the intracranial lesions, important in patients with germline retinoblastoma. Finally, only in certain advanced cases we will perform an investigation of other compartments, as bone marrow aspiration, biopsy, and a study of the cerebrospinal fluid by lumbar puncture. But we don't perform this in all the patients at diagnosis, only in some cases. So the current treatment for retinoblastoma is a multimodal treatment and includes different type of chemotherapy, systemic, intraarterial, which is the most important, intravitreal, which is becoming also very, very important in the intraocular control, in the intraocular disease, and those chemotherapies have displaced the use of radiotherapy in the recent decades in the first line of treatment. So it is no longer considered as first line therapy for intraocular disease, the radiotherapy, allowing us to decrease the incidence of associated second tumors due to this therapy. Also, the focal treatments in the maintenance phase of treatment after systemic treatment, but also for very small and localized diseases, and the emerging new therapies. So with the advances in the treatment in the recent decades, in our setting, we have achieved a survival rate which is virtually the 100% for patients. So it is important to note that here, cure is not enough. In recent years, global childhood cancer has seen a significant increase in survival, but at the expense of a lot of morbidity and mortality later on, secondary to the treatment toxicities. Therefore, we all say, pediatrics oncologists, we all say that cure is not enough. And retinoblastoma is the paradigm in this scenario. So the current objective here for us is to try to adjust the treatment, to decrease intensity of treatment, to reduce long-term toxicities, to increase the rate of the age salvage, and preserve the visual function, sorry, as we can. So the conservative treatment from retinoblastoma, with the development of intraarterial chemotherapy, we have get to put treatment like delivered locally with an access like directly from the femoral carotidia and then the ophthalmic artery. We go directly to the eye, to the posterior part of the eye, to the retina, and then we deliver it locally the drugs, getting higher concentrations than the chemotherapy and than the endovenous chemotherapy, and now with these therapies, we have achieved a higher rates of the eye, the global eye salvage. So this therapy, we can use it in people, children who weight more than at least 6 kilograms with no vascular abnormalities, who have intraocular disease which requires systemic treatment, but which do not meet criteria for enucleation, I mean group E. And in some groups, they exclude patients with bilateral disease. Their first line treatment is with systemic chemotherapy, but our group has an extensive experience treating these patients with intraarterial chemotherapy with very good results. So what is the current status of systemic chemotherapy nowadays? So it is primarily used in 3 settings. In patients with advanced intraocular disease who have undergone enucleation, where examination of the pathologist reveals evidence of structural invasion with the possibility of metastatic spread. Also in patients with metastatic disease, whether local, regional, into the central nervous system, or in other parts in the body. And also in patients for whom intraarterial chemotherapy is not possible for various reasons, as I have already told. So the drugs used are diverse and have changed very little in the recent decades. Primarily, we use vincristine, carboplatin, etoposide in almost all the cases, but there are a lot of other drugs that we can combine in different phases in the treatment and depending of the intensity of treatment that we need. So, however, the systemic chemotherapy has multiple toxicities. In the short term, the most important that are the hematological toxicities, producing aplasias, requiring transfusions, and periods of significant risk of infection, as well as gastrointestinal toxicities with vomiting, diarrhea, malnutrition, also nephrologic and hepatic toxicity, and very, very important, the ototoxicity, the hearing loss due to carboplatin. In these patients, they require serial audiometric monitoring. Furthermore, their hair and their physical appearance is affected, as we all know, causing psychological consequences. And of course, and less important, not less important, very, very important, the time toxicity. Since these regimens are often hospitalized and require multiple hospital appointments, affecting the quality of life of patients and their families. And it is not all. There are also a lot of long-term toxicities. The permanent hearing loss that we were talking about, and above all, the incidence of the second malignancy, the second neoplasias, is very important, especially in those patients who already have a germinal predisposition and who are mainly associated with external radiotherapy and drugs such as etoposide. They can have other multiple toxicities depending on the drugs and the doses used, with hormonal, endocrinological, and reproductive problems being very, very important in some patients above all during the adulthood. So regarding the follow-up of these patients, there are 2 scenarios. There are patients with an sporadic or non-hereditary retinoblastoma and patients with hereditary retinoblastoma. So in the first case, follow-up will depend on the treatment received. During the first 2 years, approximately, there is a risk of relapse. Yeah. So close ophthalmological examinations are performed and are necessary, and also in patients who have undergone enucleation, receive adjuvant chemotherapy due to the risk of metastasis after enucleation. In patients that we have not done a conservative treatment, we need to follow up these patients with an imaging. So a cranial MRI is performed every 6 months or yearly until 2 years approximately from the end of the therapy, of the treatment. And after all of that, we start to follow up the potential treatment toxicities. So if they have received chemotherapy or radiotherapy, more rarely now, follow-up is adjusted for possible toxicities. There are some guidelines from the Children's Oncology Group that adjust the follow-up of this patient based on the drugs and doses received. And what about patients with hereditary retinoblastoma or germline retinoblastoma mutation? Follow-ups will be adapted to their condition of predisposition to associated cancer. So in addition to previously described controls, these patients need individualized management. As we have already mentioned, a small percentage of patients may present with a synchronous tumor in the intracranial level, especially in the first 2 years of life. So it is essential to perform a cranial MRI at the onset of the disease. Some groups recommend to follow up every 6 months or yearly until the age of 4 years. But the benefit of this practice is controversial, and we need for these MRIs, they are all of them done in these little children under anesthesia, and they are children who have a lot of anesthesias because of the ophthalmological explorations of the intraarterial chemotherapies, and the side effects of the anesthesia in this child during the infancy could be important. So this is not that clear. And as we have already mentioned, these patients have an increased risk of second malignancies, especially during their adulthood. A recent study in a middle-income country cohort in Argentina, where patients still receive more systemic treatments, identified a 700-fold increased risk of sarcomas in those patients who had received radiotherapy, and up to 140-fold increased risk of a secondary leukemias in patients who had received chemotherapy, especially etoposide. So there is also an increased risk of melanoma, some gynecologic, head and neck, breast tumors during the adulthood has also been identified. However, periodic follow-up by imaging has not proven to be a good screening system. So what is currently recommended now for these patients is a complete physical examination every year, focused in the skin, also on dermatological examination during the adulthood, and adequate health education from the onset of the disease to the prevention of other risk factors in adulthood, and also for them to be autonomous in the early detection of symptoms. It's important to educate them to tell which signs, alarm signs of a sarcoma or a brain tumor, or what they have to ask if they begin with symptoms. They start with symptoms. And we are concluding. One of the most important advances in recent years is the increased understanding of the biology of disease. which is allowing the classification of retinoblastoma into molecular subtypes, depending on the molecular alterations, and even we can extrapolate it to the immunochemistry. So there are two subtypes with apparently different aggressiveness profiles, and which is likely to allow further stratification of patients by adjusting treatment and reducing intensity of treatment in a large group of patients, and also intensifying chemotherapy in those who can require it. And in addition, and very important, there are a lot of multiple studies about liquid biopsy underway. The aim is to detect circulating DNA from the tumor cells in blood, in cerebrospinal fluid, and also in aqueous tumor by detecting biomarkers such as CRX, GD2, MECAN, and others. This will help in diagnosis of non-enucleated patients, but also in the early detection of disseminated disease and in the disease monitoring during the treatment. We collaborate in one European study who aimed to assess the feasibility of the biomarkers, to establish a long-term collaboration between centers in this aim. And also we collaborate with another projects about liquid biopsy, supported by one of them, supported by the Ninetta del Sol Foundation, of which Carme will explain more you later. And finally, just two words. It is worth to mention that there are multiple research studies in the development of new therapies, either through the use of molecules that target the pathways involved in the pathogenesis of the retinoblastoma, and also the use of immunotherapy in different forms, including the development of the CAR-T, or even use the oncolytic viruses, as Dr. Català has already told you. And just to sum up, some final take-home messages. Well, retinoblastoma is a rare condition, even among pediatric cancers. Germline ERN-EYE testing and referred to genetic counseling should be performed in all cases of retinoblastoma. Overall survival rates in our setting are excellent, and the aim should be to preserve the eye and the visual function and to prevent the long-term toxicities. So treatment depends on the staging and the patient characteristics. Intraarterial chemotherapy is safe, is feasible, and is effective in most cases. Systemic chemotherapy should be reduced in germline ERN-EYE affected patients. Obviously, radiotherapy should be avoided. Surveillance and follow-up are needed and should be tailored to the individual. Molecular characterization of the circulating DNA would help us to stratify patients and to adjust treatments. And new approaches and targeted therapies will improve the patient management in the future. So, well, thank you very much for your attention. Let's introduce our last speaker. She's Carme. Carme is the mother of Anna and Julia, and she's a professor at the Rovira and Virgili University of Tarragona, and is the president of Ninetta del Sol's Foundation, and she's going to give us a talk from the parents' perspective of kids with retinoblastoma. So please, Carme.
Thank you. Thank you, Maria. So good afternoon to everyone. And first of all, my husband and I would like to thank the organization and Dr. Català and Maria, which we know, for inviting us today. We believe it's very important to listen to parents also, to understand their needs. And through this presentation, we will try to show how we have been dealing with the different stages of retinoblastoma that you have been explaining here with our daughter. So let's begin with presenting us. Let's see who we were before diagnosis. On May 2018, we were a normal family, if there ever was one. We had 2 daughters, Anna, who was 4 years old, and Julia, who was 8 months old. And Joan Carles worked in a driver school, and I worked at the university as a professor who lived in Tarragona, as now. And Tarragona is a city located 100 kilometers from Barcelona, more or less. So let's begin with the first symptom. We remember exactly the day because the 23rd of April, it's a very special day in Catalonia, it's Sant George. And we noticed that Julia's left eye deviated slightly outward. Only very occasionally, you have to look at it very, very carefully to see it. But since we had a checkup with the pediatrician that week, we tell her. So she didn't give any importance. She said that sometimes it happened, and she didn't examine the eye. So she suggested to monitor it for a few more days and to come back if it became more frequent. So that's what happened. In the next days, we pay more attention, and it was clear that Julia had strabismus very occasionally in her left eye. So we insist. We went again to the pediatrician, and we insist. And she didn't examine the eye again, but at least she scheduled a visit to the ophthalmologist for Julia without any urgency, because she said it's a normal thing. So here, what we want to remark is that we didn't know anything about retinoblastoma, because I think it would, if we had known it, we had insist even more, because we don't think on such serious thing. And we will also remark also that we know a lot of stories of other moms that had to insist too much to be listened. So we want to change that. So our main concern when we was waiting outside the door of the ophthalmologist was that, oh, our poor baby had to wear glasses with 8 months. This is our main concern. So as you can imagine, it was a shock when we entered the room and they examined the eye, and they noticed that there was a big tumor in the eye, in the left eye. And they sent us to Sant Joan de Déu Hospital immediately. We left everything, we took the car, and we went to Barcelona to confirm the diagnosis. And in that moment, everything stopped. This is the way of expressing how we felt. We felt like empty, as we had to start from scratch. We couldn't believe it. A tumor in the eye. It was such a baby. It's 8 months. And so we have many doubts, many uncertainties. We felt uninformed. We felt lonely. We were so afraid. And everything changed that day in our lives. First of all, we had to deal with the new situation. We had another daughter who was 4 years at that moment, and her grandparents didn't live in Tarragona as now. They live 100 kilometers in a town, so they had to come every time we had a checkup, we had a treatment or anything. And she felt a bit lonely. We know that. We know it was not easy for her. So it's not the illness, it's all the family organization, it's also the work. I requested leave of absence from work to care my daughter, and Joan Carles had flexible hours to be able to go to Barcelona. But not everyone has these facilities. Another thing is how to tell to everyone, how to tell to the grandparents, the aunts, the cousins, the close friends, how to tell at school friends. It's not easy to explain to people, to tell people what is happening, and not everyone understands it, nor the seriousness, nor how we feel. But of course, we don't blame anyone, because you cannot understand this if it has not happened to you. So what about the treatment? Fear, uncertainty, we feel emotional damage. We think there are a lot of emotional damage to children and parents. And with COVID, the conditions at the hospital were very bad. And Julia needed 2 intra-arterial sessions and 1 laser session. we were told that it was like a kind of record. It's only 2 intraarterial sessions, but 4 years later, another laser session was needed. And we wanted to remark that taking this step back after being stable for 4 years was kind of desperate. The checkups became more frequent again during a year. But we also had positive things. The first one is the trust. We trust the medical team because we know that they are experts in the treatment of retinoblastoma, as you have demonstrated here in the presentation. And on the other hand, the medical team in Sant Joan de Déu offers very close relationship to families. They always have been very clear to us. The first day, they said that retinoblastoma is like an obstacle course. Sometimes everything goes well, but suddenly something goes wrong. The other positive thing, the other positive thing we want to remark is the fact of meeting other families in the same situation, because we were lucky because without COVID, we had the opportunity to meet other families at the checkups, and not all the families are so lucky. In other hospitals, families do not share space. Knowing other families give you hope, especially if they are families that have been already gone through the first few months after the diagnosis. So it's very important, this contact. And what about checkups? You mentioned that in retinoblastoma, there are so many checkups, so many drops in the eyes, so many pricks, so many COVID tests, so many times forcing Julia. So uncertainty, fear, and emotional damage to children and parents again. But we had positive things that we learned of this. We knew plenty of good people during this journey, and we looked at life in another way. We appreciate the little special things, and we learn not to worry for nonsenses. We changed things at work also. Joan Carlos left his former work, finished his bachelor degree in psychology, and he is working part-time in our foundation that I will mention briefly later. And I worked part-time at the university until a year ago because I wanted to have time for the foundation. Now I am working full-time at the university, but I always found time for the foundation also. And I redirected my lines of research toward more motivating areas. And now I am currently working on a mobile application to achieve the early diagnosis of retinoblastoma and other childhood eye diseases. And we created the Neonatal Dentistry Foundation that Dr. Maria mentioned because we have a life goal. We are very proud of having a life goal that is to revolutionize everything related to retinoblastoma. So we would like every family and every patient to have the most information, the better. One of our goals is to spread the symptoms of retinoblastoma to achieve early diagnosis. As you mentioned, is very important. We are creating a network of families and patients because we help each other a lot. And we promote the research, especially regarding second tumors, as Dr. Maria mentioned, which worries us families so much because Julia has retinoblastoma, hereditary retinoblastoma, we know that. And it's true that there are, you can take care of the skin and that stuff, but the best thing could be to have a liquid biopsy that tells you that something is wrong and that it's only the beginning and the treatment is not so hard. And we have a camper van and we travel as much as we can, and we are really happy. So thank you very much for your attention.
Thank you very much, Carme.
You're welcome. Thank you for inviting us.
Very emotionally and very amazing and interesting also to see the patients and the families experienced, and also all the work that you have created with the foundation. We didn't have the time to meet a lot or to we just meet sometimes.
Yeah, don't worry.
But you are always ready to help and with a lot of ideas, promoting studies, projects to help the other families, and this is amazing. So thank you very much. So thank you everybody for your attention. Thank you everybody.